Good evening, everybody, or good morning, depending on what part of the globe you're on, and welcome to our virtual series. If you don't know me, my name is Ronnie Blumenthal. I'm the Executive Director of the Phelan-McDermid Syndrome Foundation, and I'll be opening and closing today's session. Before we get started, though, I'd like to take a moment to thank our sponsors. If I could have the next slide. We had two gold sponsors, the Turner's Tribe, which is in honor of Turner Jones, and the Robert and Ava Worthy family. Thank you very much. And then to our silver sponsors, AMO Pharma, Autism BrainNet, Berio and Associates Inc., Neurin Pharmaceuticals, and then we have an additional donor who has remained anonymous. We thank all of you for your support. This is the reason we were able to offer this free to all of the participants, and we're delighted to have such a great series to present to you. We really appreciate all of you. Thank you again to our sponsors. If you've not already done so, can you please download your conference mobile app? This will make it almost like you're in Kissimmee, Florida. I know everybody is longing to be together, but the best way to connect is through the app. It is available on both the Apple Store and on the Google Play for Android. The code is 20, lowercase PMSF 20. And we hope that you'll get on there, interact with some of the attendees. We have lots of small breakout groups, etc. So please take advantage of that. We had an overwhelming response when we asked for questions in advance. So we are not going to have live questions for this session. Other sessions will include Q&A, but this one will be closed because we want to spend as much time as possible addressing those that we got in advance. We also have deferred a couple of types of questions. Most of the epilepsy questions have been deferred because on August 19th, we have Dr. Jimmy Holder presenting on sleep and seizures. So we thought that you would get most of your questions answered there. And then on August 5th, we have Tazy Kohlenberg and some families who will be speaking about psychiatric illness and psychiatric regression. So we again would prefer that you attend those sessions to get a comprehensive view of those topics, and I'm sure your questions will be answered there. Next slide, please. So I'd like to introduce the Medical Advisory Committee, and I'm going to ask them to introduce themselves because you should read their bios on the app. They are long because they are prestigious and expert with our population. We're really glad to have them all aboard. I'm going to start with the chair, Alexander Kolevzon, who is going to do a very brief presentation just to show you some of the initiatives that are going on that involve our MAC members. And then I'll come back and introduce you to the rest of the gang, and we'll get started with questions. Okay, Alex.
Hi there, good morning or good evening, everybody. Welcome to the annual conference. It's absolutely pouring in New York and nighttime, so it's a little bit of a peculiar time, but I'm very happy to present just a little bit about the work that we've been doing in general, nationally and internationally, and then also introduce the Medical Advisory Committee. I think we should be all set. All right, wonderful. So over the last 6 years or so, we've established what we call the Developmental Synaptopathies Consortium. This has been a really amazing group of people that exists across 6 different sites in the US. We just got refunded for another 5 years with the goals to really do a very comprehensive job of characterizing the clinical features of Phelan-McDermid syndrome across the lifespan and to track the natural history. This study in particular, this new iteration of the study is going to include kids that are younger than 3 and adults over the age of 18. So we're going to do a lot more to try to capture as many individuals with PMS as possible. We've also shifted the focus from imaging, which is the goal of the kind of first iteration of the grant, to use more EEG-based measures to try to validate biomarkers. And then our third aim is really around kind of clinical assessment with the goal of developing a really comprehensive model to capture all different domains, medical, psychiatric, educational, cognitive, in Phelan-McDermid syndrome, and use that as an assessment tool for the future, both for research and clinical purposes. Our consortium exists now across 5 sites at Mount Sinai, Rush, Boston Children's, the NIH, and Stanford. We've collected information from about 100 families, 90 of whom we continue to follow. And we have a goal now of recruiting another 100. So this will be a a study that exists over the next 5 years, where we'll see people basically every year. And we're going to be recontacting many families, many of whom I'm sure are on this call, to continue to participate. And then we'll be recruiting new families, particularly of very young children and of adults, to participate in future studies. You know, I always want to remind folks, and I'm sure you'll hear more about this from Tacey during her talk, but we've established this neuropsychiatric consultation group, and this is a group that has about 15 clinicians really from all over the world, including some of our medical advisory committee folks. It's focused on helping local providers in the community connect to our group of experts to really help do a better job of taking care of kids in the community. We find obviously that many physicians are challenged by the kids with Phelan-McDermid syndrome, don't have a lot of experience with kids who have developmental disabilities in general. And the goal here is to call on our collective expertise to really help these physicians feel more confident and competent. And then of course, to do a better job of taking care of your kids. Part of the work has really led to some important breakthroughs in terms of developing consensus or treatment recommendations around really important symptoms, neuropsychiatric symptoms like mood cycling. This is an example of one of the protocols we've developed for mood cycling, but also for sleep, for hyperactivity, for aggression. We really have a lot of work that's been done, and we think has really kind of moved the ball forward in terms of doing a better job of standardizing treatment for the various symptoms that kids do experience. And along those kind of lines, obviously it's equally important to do a better job of developing treatment paradigms across all different kinds of conditions, including neurological conditions, dental conditions. So we've formed now consensus guidelines work groups to try to do some of the same work, but in different specialty areas. And Billy Bennett, who's on this call, will be representing gastroenterology. We have people representing physiatry, endocrinology, clinical genetics, primary care. Really all the subspecialties are going to get together with the goal of updating these guidelines that I'm sure you now know about, which were really published way back in 2014, but have a lot of room for improvement. So the goal is these working groups will get together, and over the course of the next year, for the conference next year, we will have published a much more robust, basically practice parameters around medical assessment, medical monitoring, and even perhaps treatment. And then finally, I guess Ronnie can introduce our STEAM Medical Advisory Committee, but in the meantime, until these guidelines are kind of well established, we've formed this medical advisory group to offer and promote sort of best practices for the kinds of challenges that kids with Phelan-McDermid syndrome suffer from. We've got Elizabeth Berry-Kravis from Rush, Billy Bennett from Indiana University, and Neumeyer from Mass General Hospital, Curtis Rogers from the Greenwood Clinical Genetics Center. And then of course we have the boss, Ronnie, who organizes us all, keeps us honest, pushes us to have meetings, and then filters out all the fantastic questions that we get asked by the community. And I'm done.
Thank you, Alex. If everybody, I'm just going to go in alphabetical order, and if you could just give a little bit of your background, and then we'll move on to the questions. We'll start with Billy Bennett.
Hello, everybody. My name's Billy Bennett, and I have a 4-year-old with Phelan-McDermid syndrome. I was going to try to get her to come to the video, but she's being uncharacteristically shy right now. So we won't get to see pictures of her, but she was one of the slides. If you saw the picture of the 4 kids wearing masks, sitting down with red hair, those are obviously my kids. And it's her and her 3 brothers. So I also happen to be a pediatric gastroenterologist with an interest in the digestive health of children with special health care, special health care needs. I'm also a clinical researcher. I have a NIH-funded lab that focuses on clinical informatics and what's called patient engagement, which is where we study the best way to talk to patients. And in that vein, I want to put in a little bit of a plug for a study that we're going to be running in that vein at the conference next year that's funded by PCORI, which looks at how best to communicate genetic information to families. So just keep a lookout for that. No, are you going to say hi, Cecilia? No? Okay, she's still being shy. And I spend most of my time talking to people about poop, and I've spoken to many families about the different challenges that they have, and I very much look forward to the questions that people submitted, and that's about all I have to say.
Thank you, Billy. Next up is Liz Berry-Kravis.
Hi, I'm Liz Berry-Kravis, and I've been working in the neurodevelopmental disabilities field for a very long time, since I started working on Fragile X syndrome back in 1990 or so. We have a big Fragile X clinic, but that tends to lead to referral of a lot of other neurodevelopmental disabilities, and have done a lot of work on characterizing clinical cohorts, natural history, outcome measure studies, and then translation of targeted treatments to people with neurodevelopmental disabilities. So now we have we still have a large Fragile X program. We have the PMS clinic. We're one of the sites on the natural history study funded by the RDCRC. And we see patients in clinic as well to do their clinical management during, either during their natural history visits or even outside of their natural history visits, since we have a pretty well-formed clinic at this point. I work with Latha Soraya, who's a psychologist, and her team to really look at how can we best improve the psychological well-being and the development in patients with PMS, but also how can we best measure those things if we wanted to change them during an intervention. And so we hope to be able to, continue that work. And I think, as Alex noted, this is a really important project, and we hope that we see a few pharmaceutical companies on our support list here, and we hope that there are some things moving forward into clinical trials, and we hope to have some of the measures we need prepared to do that work, but also to maintain the top care for patients.
Thank you, Liz. Next up is Ann Neumeyer.
Hi there. I'm Ann Neumeyer, and I'm from the Lurie Center at Mass General Hospital in Boston, Massachusetts. So it's evening here also. And I'm a pediatric neurologist. I've been caring for children with autism and neurodevelopmental disabilities for the past 30 years. And my interest in PMS really sprung out of my work in caring for children with autism. And over the years, I just started collecting, seeing more families and watching their children with PMS growing up. And so we started a clinic at Mass General. I spend a lot of my time working with the Autism Treatment Network and doing clinical studies to try to improve the health of children with autism and neurodevelopmental disabilities. And I'll stop there.
Thank you, Ann. Last but never least, Curtis Rogers.
Hi there. I hope you guys are having a good night or day. Some of my friends in Australia have already noticed I've got an Australian PMS shirt on from a fundraiser there. So I have been with the group since its inception, and our genetics center in Greenwood was one of the driving forces in starting PMSF. We described some of the early cases with that. I've been doing genetics for over 35 years. I've been to every conference that has been held, and actually have seen many patients with PMS, and have a new family from Georgia coming tomorrow to our office to be seen. So actively involved, I'll say, in clinical management and evaluation, not so much research.
All right, thank you very much, Curtis. I'm going to introduce now Jackie Jacobs, who's been working with us for, well, since we started our PCORI grant. So I think that's like 6 or 7 years total now, since the grant has come to a close. And so she is very familiar with our families and has reviewed all the questions. Is going to be the person who will be addressing each of the committee members. So Jackie, are you ready? You have to unmute.
I'm ready. Ready to go? Thank you. So as Ronnie mentioned, we received almost 100 questions that we distilled down into a shorter list. We're going to try our best to touch on most of those tonight. So just to get started with Dr. Rogers, a founding member of PMSF. Dr. Rogers, can you give us a brief overview of the genetics on Phelan-McDermid syndrome?
If you can pull the slides up, I just want to talk a little bit about the clinical features. I'm sure we've got some new families on here who've never been to one of our family conferences. So the 22q13.3 deletion can be varied in size. So we can have just a single point change in a letter of DNA in the SHANK3 gene, and then we can have deletions that include SHANK3, and those deletions may be anywhere from 30 kilobases or 30,000 pieces of DNA up to 12 or 13 million pieces of DNA, what we call megabases, million pieces of DNA. The phenotype is indeed variable. There is some correlation. I know this question was on the list. There's a correlation somewhat with deletion size and the developmental issues. That is certainly not absolute, but in general, we could say a larger deletion is associated with more significant developmental issues. Some of our data has shown that if you have a smaller deletion and milder developmental delay, you may be more likely to present with autism or autism spectrum disorder. As far as physical features, we really have not pinned down which feature may be associated with which gene, but these are the ones that we've seen in more than 75% of individuals with PMS. Hypotonia is a very big problem, as well as a developmental delay. And many of you parents know that your child has delayed speech or absent speech, and some of you may have a child who had speech and then lost speech. So sometimes we will see a regression like that. We used to think the children with PMS and the adults were larger. We now know after more data that they have normal growth. Decreased perception of pain is a problem, and when you add that with an inability or decreased ability to communicate, that causes significant problems for parents when their child does express pain. Where is that pain coming from, and how am I going to find this out? How are we going to manage this? A lot of mouthing and chewing behaviors. Interestingly, this past year, I saw the initial patient for follow-up that we had described, 1989, something like that, with Phelan-McDermid syndrome. He is fairly healthy, but he still exhibits significant chewing behaviors, which he showed even as a young boy. Autism, we know about. Next slide. Switch the slide. These are present in 50% of individuals, and these are the features that you may recognize if you come to the conference that are common in some of the children and adults with PMS. Long eyelashes that most women would kill for, large fleshy hands, and especially dysplastic toenails, underdeveloped brittle toenails, somewhat puffy cheeks, which gives the eyes a little bit of a deep set appearance, decreased perspiration, which means the children may have a tendency to overheat. So when we have our meetings in Florida, we always have to be concerned about that, and significant feeding difficulties in some children. Next slide. and in fewer people, renal problems, GE reflux, although Billy may argue with that, dental problems, seizures, cardiac issues, and these slides are available on table form at Gene Reviews in a review that we have written for that government-run database, and anybody can access that. It talks about all the problems and features that can occur in PMS and is a good resource for families to use. I would imagine Ronnie's got a link to that on the website too. And if you'll show the last slide, I know there was a question in there, Jackie, about how can I tell whether my child is going to be severely or mildly affected? And we can't tell that exactly because every child is different, every deletion is different, and there are other genes within the deletion as well as outside of the deletion that may impact what we see as a presentation in that child. In a recent study by Catherine Zayats, who is a genetics resident at the Greenwood Genetics Center, they looked at some of these genes that are highly expressed in the brain, and they focused on those because the driving issue is those developmental problems, and picked out 5 genes. I added a 6th gene in there. You'll see ARSA that doesn't have a box, but we're going from the bottom of the number 22 chromosome, the Q arm, up toward the centromere, which is that little dented place on that chromosome. And so you can see that these genes that are highly expressed in the brain are not really that close to each other. They are roughly 7 million pieces of DNA spaced, and are spaced along that segment of the chromosome. There are others, but they are not as highly expressed. We've recently put together a little statement about some of these ARSA, which causes metachromatic leukodystrophy and is a recessive condition, and then MLC, which can lead to brain anomalies. So I will stop it there.
Great, thank you so much for that. Can you just comment on what's the difference between a 22q13 deletion and a duplication? Is a duplication PMS?
Not in my book. I would not call a duplication PMS. Boy, Alex is smiling because we always seem to get back to this discussion of what is PMS and whether you define that clinically or whether you define that based on the cytogenetic and molecular findings.
In this case, you and I agree completely, Curtis.
Yes, I know. And I personally feel like I want to have that SHANK3 gene involved in that deletion. I would not call a duplication PMS. So duplication just means there's extra 22q13.3 material as opposed to missing material that we see in the deletion.
And then are there, what tests are required to confirm a de novo diagnosis? So let's say someone is concerned about a non-PMS sibling of childbearing age. Should they have any additional genetic testing done?
Well,
Jackie, am I allowed to interrupt for a second?
Sure, go ahead.
Sure, if you two want to answer together, go ahead.
As you asked that question, it occurred to me that there's an important distinction because Curtis also mentioned point mutations that can cause Phelan-McDermid syndrome. It is possible that you can have a duplication of a single piece of DNA, a single letter, causing a duplication but disrupting the function of the gene. So that's kind of a duplication mutation that still causes PMS.
Right. So yes, anything that can disrupt the gene. I'm trying to remember what the question was now.
Sorry.
That's all right.
It was about additional genetic testing for
Oh,
non-PMS.
yes, the additional genetic testing, at least in genetics, I think if we find a deletion in a child, we are always going to test the parents to, one, ensure they don't have it, and to make sure that that deletion that we're seeing in the child is not indicating a balanced translocation in a parent that may place them at high risk to have another child who has Phelan-McDermid syndrome. We're also looking for ring chromosome 22 to make sure that that is not present, because that brings up some other issues in management. Now, as far as studying the family, we've already studied the parent. I would say if the parents have normal chromosomes, then that risk is very low, less than 1% for sure, that another sibling of that affected child or a sibling of a parent would be carrying a chromosome variant that would lead to Phelan-McDermid syndrome. However, for peace of mind, if that's a parent wanted to have another child tested for that specific variant seen on microarray or on chromosome studies, they could do that, as could other family members. That is probably, you're going to have to pay some money for that. That may not be covered by your insurance. It may. Just depends on what your insurance coverage is.
Great, thank you. Just moving on to another hot topic, we received a number of questions regarding GI issues. The questions touched on issues like constipation, reflux, motility, gastroparesis, and maintaining a healthy gut. So we're gonna address those, and then we have a couple others that are more specific to toilet training that will open up to the panel. So Dr. Bennett, a few questions for you. Just starting off, what causes constipation, and what are the most effective ways to relieve constipation?
This is a great question, and it's what I spent about 50% of my life talking about. And so in PMS specifically, there are several things that end up resulting in constipation. And I would put it down to 3 different factors that are probably at play. So the first is, as Dr. Rogers mentioned, hypotonia is this almost ubiquitous symptom in PMS. And so, there's one area, the colon, that has a lot of nerves and muscles in it. And so there's usually some degree of slowness and, hypotonia to the colon. The second part of it is that there's also hypotonia in what we call the pelvic floor, which is this sheath of muscle that sits right below your bottom, and you have to relax and push and kind of coordinate these muscles in a very specific way to poop. And so kids with PMS have lower tone in those muscles, so their ability to have an effective bowel movement is impaired. And then the third part, that it's sort of an interesting combination with these other things, is that a majority of children with PMS lie on the autistic spectrum. And so what this causes is less ability to sense that your rectum is being distended. And so that's, and I never know if what I'm talking about is gross to normal people. And I say the word rectum and poop and bottom and all the time, and I never know if I'm offending people. So stop me if anything starts to get gross. But the way that human beings sense a bowel movement is that the rectum fills up with poop, and the rectum is the very last part of your large intestine, right before the opening of your bottom. And then that distends with poop and stretches, and then some sensory nerves send signals from there to your brain, and then that's what we call the sensation of I have to poop. And it's a unique sensation. You wouldn't mistake it for anything else, but kids with PMS often do. Either they don't sense it at all, or they sense it as discomfort rather than an impetus to go to the potty and poop. And so that the whole thing that results in is the poop sits in there longer, it gets drier, it gets harder, it gets more difficult to pass, and then that just creates this vicious circle where the poop just kind of builds up and builds up. So I think that's answering part 1 of the question, is why do kids with PMS get constipation? And then the second question is, well, what do you do about it? And really there's again, the rule of threes, there's always three things to explain everything. There's three ways that I tend to approach constipation in PMS. So one is to get the poop really soft, and that's job one. By far the most effective medicine to do that is Miralax. And you just take a lot of it. You either start with a huge amount of it to clean everything out, and or you use a small amount on a daily basis to keep the poop soft. Nobody is going to get rid of constipation with hard poop. You have to start with having soft poop. The second is that a lot of kids that have low muscle tone, they do better if you provide some stimulation to those muscles. And that, usually that's what we call stimulant laxatives. So there are things like Senna and Dulcolax or Bisacodyl. And those can provide an extra push. And then the third thing, and honestly, this is a big and often overlooked thing in PMS patients. So it's using therapy to deal with it. And I think ABA therapy tends to be the most effective, where you really try to work on the behaviors, the stool holding, the lack of responsiveness to rectal sensation. Just from a personal example, Cecilia has, my 4-year-old, she has been in full-time ABA therapy, like 40 hours a week for several years. And they taught her how to poop. They had a boot camp where they spent, a week or so with her just hanging out in the toilet with all of her favorite things. And then, and even in states where that degree of ABA therapy is not available, I think including that in the behavioral plan can be quite beneficial. And then in concert with that, physical therapy is often helpful. Most physical therapists are also trained in what's called pelvic floor physical therapy, where they can teach even kids that have developmental delay, can be taught to control the muscles in the pelvic floor better. And so I would say that people that have success with constipation are those that use that kind of three-part strategy. And some only need different parts of it. But I think having a holistic approach where you're dealing with each of the elements, with the fact that the stool is hard, with the fact that the colon needs a little bit of a push, and with the fact that there's a very significant behavioral aspect to it, that if you address all those things, then that's your chance of having the most success.
Great, thank you. And is there any relationship to intestinal infections and either diarrhea or constipation?
In PMS, usually no. So constipation is not a sign of infection. I have had many patients that have come to me and said, well, this doctor or my aunt's cousin's roommate said that clearly this is a sign of some kind of overgrowth or infection. And that is simply not based in science or medical evidence. Constipation is invariably a neurological / behavioral problem. That is not going to keep some people from testing for intestinal parasites or intestinal infection, but that is there's supposed to be lots of bacteria in your intestine, and they are not usually related to constipation. There are notable examples that I don't think are probably worth discussing today, but I would say that short answer to your question, no. For diarrhea, sometimes yes. There's many chronic GI infections that can cause diarrhea, but for constipation, I would say no.
Great, thank you. You touched a little bit on your answer to the previous question about toileting. So let's talk about that for a minute, and I invite any of our other panelists to jump in for any of this too. Why is it so difficult to toilet train my child? What can I do to help? And other than just children, adults who need support with this?
Well, I mean, first of all, I would say that my approach to this problem in toddlers would be the exact same as my approach to it in someone who's 40. The same process is going on really at all ages. And I think that, toilet training is a behavioral process. It's a combination of, once again, rule of threes. There's three things that have to happen. is that you have to have awareness that you have a bowel movement. You have to have a bowel movement that is where you can pass it. So, so a soft enough bowel movement. And then you have to have willingness to have a bowel movement. And so that really is largely a behavioral issue. And I really, and this is why I'm a big advocate for insurance paying for ABA therapy for children who are on the autistic spectrum, is that it is, stooling behavior is something that can really be helped with different therapeutic approaches. So I would say my short answer to that question is therapy, 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 and some Miralax.
Yeah, I would agree with that. And we just did a big, large analysis of the entire forward database, which is this big Fragile X natural history study, and analyzed the factors that were most associated with very slow toilet training. And this was both for bowel and bladder training, and published the article recently. And really, language was the biggest effect in Fragile X anyway, in terms of who toilet trained very late and who didn't. And then autism was kind of the second biggest impact. So those kids who are not communicating well and not responding to their body signals well. And so we have some of the psychologists who worked on these plans where you just say, okay, this patient's not going to tell us when they need to go to the toilet. We're putting in this structured toileting plan where they're going to the toilet every so often. And that's really the only way we expect to ever train the patient. And then, utilize therapy surrounding that and kind of start, like sometimes some of those patients who are a little bit less communicative and lower functioning, for lack of a better term, are, the family is waiting for those kids to, quote, be ready. And sometimes if you wait too long, it becomes a habit to not toilet train. So just picking an age at which you're going to go ahead and implement a behavioral strategy like that, I think we've decided, at least in the Fragile X field, that that's important to do. And I think this is a general principle probably for all neurodevelopmental disabilities.
I think that decreased perception of pain we talked about carries right over to the decreased perception that, gee, my colon is full, my rectum's full, I need to go to the bathroom. And on top of that, then if you could perceive it, then understanding exactly what it's trying to tell you. So it's a difficult process.
Great, thank you all. One more GI question for now, and then we'll move on to some other topics. Dr. Bennett, can you talk a little bit about reflux? How is it diagnosed? What are some treatment strategies for that?
This is an excellent question. So first of all human beings have reflux. And the older you get, the more likely it is. I'm old enough that spaghetti or anything delicious invariably causes reflux. And in general, it has to do with the level of tone that you have in what's called the lower esophageal sphincter, which is the muscle at the top of your stomach that keeps everything inside your stomach. So then in somebody that has hypotonia, like somebody that has PMS, then from the very beginning, even when you're an infant, that muscle is going to be pretty loose. So it's just easier for stuff to come up. When you're a baby, it's not a big deal. It's just formula or milk or whatever. As you get older, it becomes much more acidic, and it can cause more symptoms. It can cause inflammation. It can cause discomfort. And so the main treatment for that, and this is based on a massive amount of medical evidence, the best treatment for reflux is what are called PPIs, or proton pump inhibitors. Examples are things like Prilosec and Nexium. Just so you know, this is my 8-year-old calling me from his iPad right now. This is what parenting is like. He knows, by the way, that I'm on this. So now Ellie's going to regulate. Okay. In the past, what we used were called H2 blockers. So things like Pepcid and Zantac. But if you look at our national guidelines, I think there's reference to substantial evidence that PPIs work better. There has been some concern in the literature recently about the risk of using these medicines long-term. And that's largely in elderly individuals that have underlying kidney or heart problems. I think especially in patients with neurodevelopmental disorders, I am not at all afraid to use them long-term because the risks associated with reflux, things like GI bleeding, damage to your esophagus, formation of scar tissue, aspiration, that all of these things are probably much more dangerous than the small long-term risks of using these medicines. And then besides that, there's other, but besides medication, there are other supportive things you can do, like don't eat before bed. I think all of us old people can vouch for that. Is that this is why IHOP has the early bird special for us old people at like 4:30, is because if you eat later, you just have bad reflux. So, not eating right before bed. It takes about 4 hours for the stomach to empty completely. So giving sufficient time for the stomach to empty before you're laying down is a big one. Sometimes there are beds where you can have the head of the bed raised a little bit. That can sometimes help. People try all kinds of home remedies like apple cider vinegar and some people even say probiotics and things like that. There's really not any medical evidence that kind of stuff changes reflux, but I doubt there's much harm in trying these things. But everybody's grandma has a home remedy for reflux. I have plenty of patients that swear by things that don't make any scientific or medical sense, and as long as they're not harmful, I don't object, and I just say whatever works for you, roll with it. But again, short answer is that reflux is, I would say, nearly ubiquitous in PMS patients. That treatment tends to be acid suppression with a PPI, with the addition of some supportive measures, like raising the head of the bed, not laying down soon after eating, and so forth.
Excellent. So let's take a turn to some new topics, and I open this up to anyone on the committee to answer. Let's talk for a minute about any new medical advancements. What is new with Phelan-McDermid syndrome, and specifically for some behavior issues, so hyperactivity, ADHD? Whoever wants to take a stab at that one first.
If it's okay, I'm going to first talk about some old things that people forget about. And so I'm going to talk about 3 non-drug treatments for ADHD that are super, super important. The first is sleep. If you're not sleeping, you're not going to focus. And so before you try putting your child on a medication for attention, make sure that the child is getting a good amount of sleep each night. And that can range between 8 and 11 or 12 hours. That's really important. And we all know that, because if we don't sleep, we can't focus. And the second thing is exercise is really important. And there's a reason that many of us do better after we go for a run or a walk. We can sit and focus, and it's the same for children. And especially for children who have low tone and aren't as independent, it's still very important that they get exercise. And then the third thing is behavior therapies. Don't expect a child to be able to focus if the TV's going in or there's, everyone's running around in the room. And so you have to help your child to learn to focus in specific areas. So that's the non-medical treatments. And medical treatments are actually quite similar to those that we use for children with autism. Typically, we talk about using some medicines that help with blood pressure, actually, like guanfacine and clonidine, and they can help with impulsivity. And then the typical stimulants like Ritalin, Concerta, Focalin, amphetamines, those can be very helpful for attention, but typically they don't work well in kids under the age of 7. So we only try those, and the success rate in regular children is quite high, but in kids with Phelan-McDermid, it's more 50-50, whether it's going to work or not. Anyone else want to add
Did
something?
any of
other-
you guys want to address tachyphylaxis to ADHD medications or things like that?
So some kids, when they take the ADHD medicines, they get used to them. And some kids don't. So we, because the ADHD medicines also have the side effect of decreasing your interest in eating or actually making your tummy hurt, a lot of families will only give the medicines on the day the kid has school or needs to learn, and that helps to decrease the child getting used to the medicines. Alrighty.
Anything else related to treatments anyone wants to add before I move on?
I guess I would just say that sometimes it can feel to parents like we're throwing darts at a board and it's somewhat random. And I think, you know, the issue is that every child could respond differently to different medicines, but that we actually have a pretty fair and consistent algorithm, even as it relates specifically to Phelan-McDermid syndrome, that draws on our experience with typically developing kids who have ADHD and kids with autism who have ADHD. And although it could be more challenging in Phelan-McDermid syndrome, I do think that for especially like hyperactivity, impulsivity, even aggression to an extent, we have a fair amount of success.
Yeah, I think it's important to recognize the goal of the treatment. You know, I mean, often when you have a kid with ADHD, you're expecting to use a combination of therapies, and they're gonna, by and large, you can control a lot of their symptoms. I think in the neurodevelopmental disabilities and in PMS, we're looking to take the edge off the symptoms and improve functioning, but we're not really expecting that hyperactivity is going to go completely away, or that the attention is going to be completely normal, or that the anxiety is going to go completely away. It's just going to be more manageable. So I think it's important to set the expectations, to put in all the environmental and behavioral supports and use everything in combination, but know that certain amount of it is just the PMS. And if you continue to try to raise doses or add medicines to achieve normalcy, that's probably not going to happen. You're probably better off just picking the thing that gives you the most benefit.
I'll just add one thing also, because you reminded me that it's really important when you're trying a medication for behavior that you just do one thing at a time. Because it's so common that people will try one or two different things, or they'll try a medicine and also be trying maybe an herbal supplement or a vitamin supplement, and then we don't really know what's causing what, if the child has a good reaction or a bad reaction. So we always try to do one thing at a time, and that can help us better to understand the effect of the medication.
Okay. Is there a way to predict if a nonverbal child will talk in the future? Is there a chance that a nonverbal child will talk in the future? And are there any new treatments that will help with speech and communication?
So it's a difficult question. There are many children who don't learn to talk until maybe they're 5 or 6. A lot of my families have this magic window. If my kid isn't talking by 5, then they're never going to talk. And that's not the case. Some children do. And what we really want to think about is communication. Is, can we help the child to communicate? If it's not with words, it's with signs, or it's with an AAC device, an augmentative communication device, or with pictures. So some children won't talk, and some children will, or they'll learn to communicate in other means.
I think communication, like Ann said, is the key, because not being able to communicate leads to frustration and behaviors that may result from that. So that goes a long way in helping with behavior, and as Dr. Bennett was talking about, even figuring out how to toilet train someone. Some people have a thought that using sign language, for instance, may interfere with the development or delay verbal language development. There are many studies that show that is not true. That actually enhances and augments the development of speech.
Yeah, you will also hear from speech therapists that exist in the world today that using an augmentative communication device will keep the child from developing verbal language, and so that is really not true. We try to implement AAC devices as early as possible to give the child every possible way of communicating, and there are a number of studies that show that even if the person doesn't develop speech, their interest and ability to communicate is better if they've been using the AAC device and had alternative ways of communicating earlier. And so we're going earlier and earlier with the AAC devices and using simpler and simpler tools on the technology so that you can get to the level where the child is actually able to communicate. And I think we've seen an explosion in this in recent years. Neurologists often will tell families that if the child doesn't talk by 7, they're not going to develop a lot of language. I think that is pretty true, but I have also seen kids who've talked later than 7, so it's definitely not an axiom. But it used to be that we would sort of wait till 5 to 7 to do the AAC device, but we're thinking about them now at 2 or 3.
Okay, so we're gonna jump topics a little. We're just jumping around the body. Let's talk about kidneys for a minute. How might kidneys be affected by Phelan-McDermid syndrome? What kind of treatment, diagnoses should parents be aware of?
Well, every child should have an ultrasound of their kidneys, because about a quarter of, and maybe Curtis, you want to address this because as the geneticist, you typically.
I agree with you, Ann. I think everybody ought to have an ultrasound. I think one of the questions was, well, what are you going to see? You may see reflux from the bladder toward the kidneys that can be associated with recurrent urinary tract infections, which can lead to damage, permanent damage of the kidneys. So we want to make sure that's not there. I will say this, if you have a normal renal ultrasound and if you got to avoiding cystourethrogram or VCUG, and those are normal, most of the times, if you've had one study, then we're in pretty good shape because that doesn't tend to come on at a later age. That is more a problem for younger children, is how I would classify that. So, same is true for an echocardiogram. I think every child ought to have an echocardiogram to look for heart defects. If that echo is normal, then we know there's not a developmental heart defect, and typically we're going to be in the clear, and you wouldn't repeat that study unless someone had symptoms. And I'd say the same thing for renal studies or bladder studies. If your child is, how we would handle any child, if you're having urinary tract infections, then we need to get to the bottom of that and figure out what's going on and treat that situation appropriately, whether that be with prophylactic antibiotics daily or every other day, or sometimes, heaven forbid, we may have to have surgery for VU reflux.
I just want to add that not just the kidneys, but the bladder and the pelvic floor often are a source of problems in PMS kids or any child that has got low pelvic floor tone. Just like they'll hold stool, they'll hold urine, And then oftentimes, when you've got constipation, you also have, kids that'll hold their urine, and then that can actually, result in a lot of problems. You can have the bladder can get large and not contract well. There are some PMS kids that need urological surgery, either on the kidneys if something's found on the renal ultrasound, but also sometimes on the bladder. There's a few that have had what are called bladder augmentations, where they have to construct a new bladder because years and years of holding has resulted in this kind of stretched out bladder that won't contract. A large percentage of patients that have urinary holding also have constipation. And our urologists send me patients all the time that are like, hey man, can you fix the constipation so that the peeing gets better? And so that, just like, all of us recognize that our various systems are all connected. And I think this is a good example of where, neurology and gastroenterology and urology all kind of intersect. So it's important as a general lesson to not put too many of these problems into silos, and that sometimes you need to seek out advice from multiple people, and I'm fairly biased working for a large tertiary children's hospital, but PMS kids are complex and they often need multiple specialists, and I would not send my daughter to somewhere that didn't have a comprehensive ability to take care of every system and for the doctors to communicate. And I also want to, before I forget, Jackie, is it possible for me to send a link to the general chat? Will people be able to see that?
I don't know the answer to that, but regardless, we will make sure that it is available for anyone.
Okay, it says I sent it to all attendees and panelists, but this was a GI talk that I gave about a year and a half ago that goes over some of these things, including the urinary retention and stuff related to this question. And it's on the PMSF YouTube channel. That's just a link to that.
And it looks like people are not going to be able to see it, but we'll make sure that it's posted to the app so folks will have access to that.
Thank you.
So I think this is going to be a quick one. Maybe Alex, this is a good question for you. I think you may be doing some work related to this with PMS families, but COVID-19, are there any special precautions required for folks with PMS?
Well, special precautions, I think the thing to be aware of is that some kids with Phelan-McDermid syndrome have recurrent infections, may have some immunocompromised state that you need to be careful of. I think obviously kids with PMS are putting their hands in their mouth, they're touching surfaces. I think it's much more challenging to try to use appropriate safety precautions, maintaining distancing, masks. I think we talked about the sensory sensitivities. It's extremely hard for them to kind of tolerate a mask. But those are all relevant issues. I think the biggest, most obvious risk is the change in services, right? What's happening with this shift to remote learning has been especially challenging for kids with developmental disabilities and PMS. I think that there's been a lot of experience across families of, I don't want to say, losing skills, not necessarily, but certainly having, behavioral disruption, just as a function of changing their routines. So those are all major risks, right? They're not unique specifically to PMS, and I wouldn't say that all kids with PMS are specifically immunocompromised by any means, but all the obvious kind of factors would apply.
I think I might add that any child with developmental issues may have decreased pulmonary toileting, the ability to have a productive cough and breathe more deeply. Those may be impaired, so that may place you at a little bit higher risk too.
There are numerous studies for other serious respiratory infections like influenza that show that children with developmental disabilities have a much higher risk of death, much higher risk of ICU admission. And it's one of the reasons why we're so strongly recommend the seasonal flu shot. for kids that have developmental disabilities. And there's no reason to think that that additional risk wouldn't exist for coronavirus.
Thank you all. Hypotonia. What is hypotonia? How is it treated? And especially when children are aging and growing.
So hypotonia is the kind of the resting state of muscles, and it means that they're more relaxed. So if your muscles are super relaxed, it's harder to do everything. It's harder to get up, it's harder to walk, it's harder to control your bladder. Like, all the muscles are more relaxed, and so it's harder to learn how to do things. Hypotonia is treated with exercise or physical therapy, and that's super, super important because you can develop a lot more strength and really function well if you're exercising. And so that's very important for children with PMS also. We don't have any medicines really that treat it. So right now we're basically doing therapy.
Yeah, I just want to add that the hypotonia, it's a central or brain-derived hypotonia. It's not that there's so much something wrong with the muscles. So it's sort of the set point that the brain has. And so, the kinds of things that Anne just talked about, like PT and training the brain to, be able to activate the system more easily are really the only treatments.
Okay, great. And toe walking, how common is that, and what are some treatment options?
So Liz and I see a lot of toe walking. I think that the toe walking is partly because of hypotonia. In other words, when your tone is low, it's harder to tell where you are in space. And so a lot of kids, I think, stand up on their toes, and it helps them to know where they are and to stand more securely. And that's how I explain it. There's no good scientific explanation that I know of, unless Liz knows of something, and I'm happy to learn from her. But the challenge is that when you're always standing on your toes, it's like women in high heels, your tendons get tight. And so you have to stretch. And if you don't stretch your tendons and, stand flat, then the tendon's going to get short. And usually you can manage it with physical therapy, but sometimes the orthopedic surgeon has to go in there and just lengthen the tendon, especially if it's been going on for years and years and years and years.
Yeah, I agree. I think we really don't know exactly why we see so much toe walking in kids with developmental disorders, but it's probably a combination of things, the low tone impacting it. It may in part just be an immature motor pattern where the brain is just going toward a more immature pattern. Or in some cases, especially with autism, it's thought to be a sensory phenomenon where the patient doesn't want to put their feet flat on the floor because they don't like the feel of the floor on the whole foot, kind of. So all of these things are out there. And in the end, the point is to just keep the tendons from getting too tight.
Great. And this next question, I'm going to start with Alex, and then maybe Liz can respond after. Are there any advancements in SHANK3 mutations?
In SHANK3 mutations, well, there's lots of different kinds of SHANK3 mutations. I think when I first started seeing kids with Phelan-McDermid syndrome, we saw very, very few mutations because you need higher resolution genetic techniques to detect them. I think one of the more interesting things that's developing now is differences between kids who have larger deletions or more genes affected compared to kids where only SHANK3 is affected. So it is clear that SHANK3 is responsible for the majority of neuropsychiatric symptoms and many symptoms associated with PMS. But of course, kids who have larger deletions have all other genes affected and are perhaps at greater risk for things like cardiac problems or kidney problems, for example. So we're learning a lot about the phenotype. We're learning a lot about the differences between kids. And I think eventually we'll be able to use information like the type of mutation to even predict course of illness and to know more about exactly what kinds of problems we want to be looking out for.
Yeah, another pitch for the DSC, because we have mutations and we have a lot of good phenotyping, and we can look and see what the developmental patterns are in kids with different kinds of mutations. I will say though, I've been impressed that, I think in a large group, you can potentially discern differences between kids with mutations in the gene and mutations that are deletions. But in any individual patient, it's not like having one or the other tells you where that patient is going. We've seen some kids with, good sized deletions who do really well and are kind of mild to moderately intellectually impaired and are not severe. And then we've seen some kids with a point mutation who are severe. So nothing is absolute, and we're going to need some time to pull it all together to, figure out what the predictive power of those mutations is.
I
think if we want to get really geeky, there are also several different isoforms of SHANK3, and those isoforms may be expressed in different levels in different areas of the brain. So I think where the variant occurs in the gene, whether it's if we're talking about in the gene, that point, that pathogenic variant may lead to different features just based on which isoforms it affects of the SHANK3 protein. So it's complicated.
Yeah, I mean, to make things even more complicated, I've seen kids with identical point mutations, exactly the same change, look very, very different.
That's why I get back to other genes, either within the deletion or in the rest of the scattered along those other chromosomes. If we're talking about 100 genes in a deletion, well, we've got 19,900 or so more genes that may be impacting the phenotype we're seeing in that particular child.
So the conversation has naturally turned to some research. Let's talk about that a little bit. Are there any updates on CRISPR methodology as it relates to Phelan-McDermid syndrome research?
I'm going to say not that I know of. I will say people are looking at trying, if you know which isoform of the protein is expressed in certain areas of the brain, maybe you could target that, and maybe you can increase the production of that particular isoform. I think there are a lot of things that are going to be coming down the line eventually as we learn more about neurological disease in general, whether that's oligonucleotides that can go in and encourage correct splicing of genes together which is going to serve as the correct blueprint to make a protein like SHANK3, which is incredibly important at the synapse. I think there are other ways to do that. MicroRNAs may come into play as far as being able to modulate and regulate expression of genes, whether that be SHANK3 or other genes that may partially make up for the loss of SHANK3. So there's a lot people are learning. It's just that when will that be applied to Phelan-McDermid syndrome?
I think in diseases where there's been more effort toward CRISPR, the big battle is when you have a brain disease where you actually have to get the CRISPR process working in practically, in a very large percentage of the brain cells. You know, you can do that in cells in the tissue culture plate. You can do it in some small organisms like the mouse. But as soon as you start to go with any of these, you know, kind of genetic therapies where you have to get into every brain cell, it becomes very challenging in the human brain. And so we're still, these are great, these are very promising therapies, but we just don't have the technology. We haven't quite figured it out yet. There was I think there's some of these compounds that activate transcription and could be modified, could be created so that they would specifically activate transcription of one gene. And that seems like a very promising therapy. I know there's a company looking at that, you know, and that the ideal condition for that type of a treatment would be a condition where haploinsufficiency or having half the protein isn't enough. And if you could push the production of that protein, then you might have a very substantial improvement. So again, these things are somewhat futuristic, but you know, people are actually starting to look at them.
I would mention another thing, and this has been tried in Fragile X, modulating the glutamate receptors, which is in large part, Liz can comment on this, to me seems to have been unsuccessful in Fragile X syndrome. We never quite got to that. I think the other thing about CRISPR is the fact that, are you sure that you're just changing what you want to change, SHANK3? Are you having off-site other genes being affected when you're trying to alter only one gene? So that's important. And location and delivery are everything when we're talking about gene therapy. So even if we could make SHANK3, and we could, I mean, there's nothing special about making a protein anymore. We do it all the time, and we give it IV for some genetic disorders. However, when you're talking about a disorder that impacts in large part the brain, delivery of that protein, and not just into the spinal fluid. I mean, it's been tried injecting substances directly, proteins directly into the brain, or genes directly into the brain. But as Liz said, the key issue is not delivering it into the tissue, it's delivering it into the cells themselves and improving cellular function, which then will lead to improved tissue function like the brain. But it's all got to be down at the cellular level, and that's the trick.
Thank you. That's great. I think this leads into another good topic that families always ask about. Alex, can you tell us what's going on with clinical trials? What are some updates there?
Sure. So there have been, at least at our site and nationally, 4 different clinical trials. One of the silver linings of COVID is it's giving us an opportunity to take a step back and do all the analysis that we've been waiting to do. We finished studies in IGF-1, and those were published, and we're kind of regrouping now to design a better, larger study. We're studying a treatment that's been developed by AMO Pharmaceuticals, which is one of the sponsors of the conference, specifically looking at kids with Phelan-McDermid syndrome who have epilepsy. We've just finished a study using oxytocin. There's a fair amount of evidence now that in animal models, oxytocin has an effect. It might even increase the expression of the SHANK3 gene. So we recruited about 20 participants to participate in that study, and we're analyzing the data this summer. Growth hormone is actually another study that we did on a very small scale, where we're hoping there's enough evidence that it would sort of justify some additional studies in the future. So there's, I think, a lot of different pilot trials. There's a lot of data coming out from animal model systems, and it's all going to inform hopefully larger phase 3 studies. We can involve all the different expert sites, and we can actually start thinking very strategically about what kind of treatments we want to move forward to potentially get approved in Phelan-McDermid syndrome specifically.
I think that
Alex, would you comment on how you're delivering those?
Oh, sure. So there's a whole array of delivery systems. So IGF-1 is delivered through a subcutaneous injection. So it's a very small needle in the skin. The AMO medicine is a intravenous infusion that occurs over the course of 6 hours. At least that's how the study is designed at the moment. Oxytocin is a intranasal spray. And then growth hormone, of course, is also an injection, but it's only once a day as opposed to twice a day with IGF-1. So we have yet to find the ideal delivery mechanism. I mean, kids with Phelan-McDermid, as you know, are sometimes challenged by swallowing pills. So in some ways, injections are convenient, but they're also burdensome, and they can be painful and unpleasant, especially for the parents.
I think the work that Neuren is doing is also very interesting. They have these molecules that kind of activate the same cascade as growth hormone, but don't really work through the receptor. And those molecules may have general ability to help with brain wiring across multiple disorders. We don't really know yet because they haven't completed studies, but one of their drugs is in a phase 3 trial in Rett syndrome, and then they had a positive phase 2 in Fragile X syndrome with that drug, and now they have a newer drug that they think is potentially even better, and so they're looking at PMS for that, which is probably one of the reasons they're sponsoring the conference. And I think that is a good potential route forward. Those are drugs that are oral drugs, so a little bit easier to deal with for families than things that are injections. So hopefully there are some new trials and new options for families along the way. But I wanted to, harkening back to the glutamate comment in Fragile X, so we have targeted a very specific mechanism in Fragile X, which actually was supported by about 40 basic science papers, so about more preclinical work than you could ever have, and yet the trials failed. But we have to remember we did those trials and we studied behavior in adults with Fragile X, and because the drug didn't work in adults, the companies refused to study children. We're talking about a developmental disorder here, so I think even in PMS we have to remember, we can have really hopeful candidates, but if we don't know how to run the trials or what the outcomes are to measure, we don't really have a hope of moving those things forward. So some of the work that's being done through the DSC on outcome measures and really understanding how to approach the FDA to go to younger populations first, I think is something that is going to help us with getting new treatments in the future.
What
And those
Liz
treatments
is
that
talking
were
about,
discussed, is there a certain age that is most appropriate, or a certain type of deletion that would be most appropriate to receive those treatments?
I personally think you should, if you might want to start with people who have a point variant in shank 3, because at that, hopefully you've got what I'll call a more homogeneous population, in the sense that we don't have a deletion where 30 genes are deleted versus a deletion with 100 genes. So when we talk about Fragile X, that is a single mechanism basically. So that's much easier to study, I think, than looking at chromosome deletion. So I think you really have to focus more on the gene and try to design a study that will look at those folks who have a single gene change and then extend that out to the deletion population and see whether you have an effect in them. That's just my thought, but I'm not the researcher.
Alex, would you mind just quickly mentioning whether there's an age or deletion that would be most appropriate for some of the treatments that were discussed?
So there's lots of different ways to kind of design studies, and there's lots of advantages and disadvantages depending on the age, and there's probably sex effects, and there could be effects of different size deletions or deletions versus mutations. There's a fair amount of logic that the earlier you intervene, the more benefit you can potentially see. The way that we've designed our studies is also in part based on regulatory guidelines from the FDA. So you have certain limitations depending on what the medicine is and depending on the safety profile. So for the AMO medicine, it's kids that are 12 and up. For the other treatments, it's 5 to 12. And that's just what we've done. But if Neuron comes out and does a larger phase 3 trial with their compound or medium-sized phase 2, we could design it in lots of different ways. I think my bias is to try to include as many kids as possible, obviously, to try to get families access to new treatments, even if it's just through clinical trials. And then obviously just balancing safety concerns.
I think the problem that some folks may not understand is starting your research in young children is exactly the opposite of the model that is typically advocated by the FDA, because those are vulnerable individuals. And if you have a child who has intellectual disability or an adult with intellectual disability, they're even more vulnerable. And so typically our studies are designed to first look at healthy individuals who are, quote, typical to study safety, and then you proceed from there. But almost always you go from adults down to children. And I agree with Liz, we're talking about a developmental process where you may be losing synaptic function. And to prevent that, we'd want to start with the youngest child we can first. But as she also said, you've got to have the data to be able to go to the FDA and say, look, these are our endpoints. We can prove this. We feel confident. This is how many patients, or as they call it in research, subjects we need to think we would get adequate data for this. So when you're talking about developmental disorders, it is unfortunately the opposite of the way the FDA typically works.
Yeah, and I think another approach is that we need to think of early studies in adults as safety studies. And if the FDA requires that, we can't necessarily make a conclusion that a drug won't work for a developmental disorder purely on the basis of an adult study.
Sure.
And what would be great is if we could use those adult safety studies to, measure biomarkers or signals that that we have target engagement. In other words, that we're hitting the kind of protein, or that we're doing something in the brain that we'd like to do, and then take that data and expect to have the efficacy come out in a pediatric trial of basically as young as we could go. So that, I think multiple developmental disorders are looking at that as kind of a new way of approaching this, and not the old kind of strategy that the FDA likes to use, where you get your efficacy in adults and then you do a pediatric trial after that, because that may just not work for PMS or any other developmental disability.
Well,
thank you all so much. This has, sorry, I'm getting the light to close it, but thank you all so much. I really appreciate your time. Yeah.
Let Alex speak.
I just wanted to, first, thank you guys for putting this together. Thank the other members of the committee for participating so robustly in these conversations we've been having over the last year or so. And also just to plug the community for the importance of participating in research. I mean, things like the DSC2, when we're collecting all this information over so many years, this is exactly the kind of information that's absolutely critical to developing new treatments. The way that we've conceptualized the DSC is really as a clinical trial readiness grant. And so that kind of information, when we bring it to the FDA, we say, here, this is what the population looks like. These are the really important symptoms to go after. And we rely so heavily on your participation, and of course, we appreciate it. Thank you.
Great. Thank you all so much. I am going to hand this back to Ronnie, who is going to wrap this back up for us. So thank you all again.
I just want to echo what Alex just said. Thank you all. You're a delight to work with all the time, and I'm so glad that our community got to share some of what I experience when you get together for your meetings. We're just really blessed to have you, and I appreciate that. For those of you just on kind of the housekeeping end, again, I would just like to ask you to please complete the session evaluation. You do that by going on to the mobile app, which hopefully you've downloaded by now. If you click the agenda button and you go to this session, you will see a link there for feedback. I'm in the middle of a big thunderstorm, so if you hear some rattling around, that's what that's all about. I also want, again, to thank our sponsors who you see here, Turner's Tribe, Robert and Ava Worthy Family, our gold sponsors, AMO Pharma, Autism BrainNet, Berrios and Associates Inc., Nurin, and our anonymous contributor. And then I want to also remind everyone that July 29th, we have Eileen Devine. She's a neurobehavioral therapist. Some of you may have seen her 3-part series, which we have on our website if you want to look at it beforehand. She'll be talking about reducing relational stress and building resiliency in ourselves and our families, which I can't think of a better time to learn a little more about that. And then, let's see. I would just ask that you hang on for one more minute. We have a little video from Turner's Tribe. I think you're going to find Turner to be pretty adorable. So hang on and please watch this brief video from our gold sponsor. Thank you, everybody.
Today, an entire community is painting Grady County green, showing support to a local 6-year-old boy, Turner Jones.
You wouldn't know it, until you saw him interact with somebody his age, and the older he gets, the worse that gets.
After 2 years of searching, in June, Jeremy and Brooke Jones' son was diagnosed with a rare genetic disease.
There had to be something bigger causing my child to have speech, OT, and PT and still be behind at school.
PMS, or Phelan-McDermid syndrome, not deadly, but without a cure and treatment, causing lifelong medical, intellectual, and developmental challenges.
As parents, you have hopes and dreams for your kids when they're born and how you think it's going to play out.
With a new medical reality defining their little boy's future, the Jones becoming advocates for a bigger purpose. They say it wasn't soon after their community did too, selling 600 t-shirts and covering the town in green.
And at least can, maybe answer a question if somebody asks, hey, what's all this green about today?
Turner's Tribe Day, a way to reach one more person and raise awareness.
We finally came to the realization that this doesn't define him. What's going to define him and us is how we handle it moving forward, So that's why we're here.
Showing others like Turner, even life changed by PMS can be your very best one. The Jones tell me proceeds from their shirts go towards the national nonprofit researching PMS. They're also planning another pre-order of shirts in the next couple weeks. Reporting in Grady County, Noelani Matthews, WCTV Eyewitness News.